So this video is assessment of the patient with spinal trauma. And by that I mean following some kind of collision or road traffic accident. I don't mean spinal cord trauma due to degenerative disc disease. The most important thing after spinal cord trauma is to be able to assess the animal from a prognostic point of view so that you can give a prognosis to the owner and manage their expectations and tell them whether or not it's likely that function will return. So in this video, we're talking about spinal trauma, and specifically, this is when a pet has suffered a spinal injury, either accidentally or perhaps not accidentally, usually an impact from a force such as a road traffic accident or a collision with a stationary object. We're not going to talk about spinal injuries due to degenerative disc disease or other intrinsic diseases. So, when we are presented with an animal with a spinal injury, these are the 7 main steps. And in fact, in this video, we're not really going to go through all of these steps because really some of them, like provide analgesia, have been covered in other videos that I have done and really are a video in themselves. So, but in a nutshell, this is obtain a good history, establish the prognosis. So important for first opinion practice. Is this case going to do well with non-surgical management? Does it need to be referred? Or is the prognosis for walking again hopeless? Stabilize the other injuries. If an animal has been hit by a car, it's unlikely that there is just a spinal fracture. Provide analgesia. Dealing with the spinal cord injury, then we need to reduce the vertebral malalignment. Provide stability in some way, so cage rest, internal fixation, or possibly an external splint. And in some cases, decompression, and this is not usually necessary if the vertebrae are alignment. So our first step is that we need to obtain a good history and do a good physical examination. I'm going to tell you about a case that I was presented with probably about 2 decades now. It was a little cat, a little kitten, and it had been playing overnight, we presume. The owners had left the house and come back and found that this cat, that was one of siblings, was unable to walk. So they naturally immediately presented it to the emergency practice. And the emergency clinician did what they thought was a good physical examination and then managed the cat with pretty symptomatic care. And the cat made a good improvement overnight. And I saw the cat the next morning when I came in. I was asked to assess the cat. And they said that as the cat had made such a significant improvement, should we just discharge the cat back to the owner? Well, I thought, well, I looked at the cat, looked all over the cat, examined it for pain, didn't seem to be painful, and seemed to have very minor neurological deficits. But I thought, well, why would a young cat be presented with a spinal cord injury? That would be very, very unusual unless there was a trauma. So I recommended obtaining some spinal radiographs, volunteered to do it myself. And when the cat was suitably relaxed, I opened the cat after a sedative. I went to intubate the cat, opened its mouth and saw that. So what I'm basically saying is that my physical examination of myself and of the previous vet had not been good enough to identify that the cat had a stick sticking out of the back of its skull. And this was entering at the craniocervical junction and had pithed the spinal cord. You may say, why not? Well, I had opened the cat's mouth a little bit, and the cat was a little bit resentful of me doing that. It was only a kitten, so I'd only looked briefly at the mucous membranes and checked that there had been normal jaw tone. And the amazing thing about this cat is it let me manipulate its neck without showing any apparent distress other than slightly flattening their ears. Here is an image of the MRI scan that we then took of the cat, and we can see the stick entering here, going through the junction between the skull and the atlas, and we can see that the stick is broken here, and that it's penetrating out the back of the other side of the vertebral canal, and it is really sort of going right through what appears to be going right through the spinal cord here. At which point I started to get quite worried. So I'd ask you, what would you do next? Would you pull it out and pray that there isn't massive hemorrhage, bearing in mind that the vertebral artery is going into the basilar artery just here? We can just see it there. Just hope that God is on our side, and also that the stick doesn't snap completely, considering that it is definitely bent there. Do a surgical approach to the craniocervical junction, which I can tell you is quite challenging, especially as the vertebrae, or refer. Well, I had a anaesthetized cat in front of me, and I was the person that somebody would refer to, and I was very challenged with this, and I eventually decided to do option A, pull the stick out, and these are actually the images after the stick has been pulled out. And fortunately the stick did not break, and the cat did wonderfully and continued to improve and was discharged on antibiotics later that day. So the moral of the story is always take a good history and do a good examination. And if an animal is found acutely non-ambulatory, and it's a young animal and there isn't any obvious other cause, then you should still consider trauma. If the animal has been traumatized, then you need to assess for other injuries. This was a dog that was referred to me with a broken neck, and it's been in all the excitement of the fact that the dog had a neck dislocation. It had been completely missed that the sternobrae were also broken in this dog attack, and were penetrating up and pushing the heart back, which made a compromise to the anesthesia for this one. So is the animal in cardiovascular shock? Is there more than one spinal injury? That's very common. You shouldn't just make radiographs of one area. You should take the whole spine. Could there be a diaphragmatic hernia? Are there bladder injuries, other fractures, ruptured bile duct, traumatic cardiomyopathy, or a soft tissue injury? I'm not going to go through all of those. This is really just standard and basic emergency and trauma care. The most important point from a neurology point of view is to establish a prognosis. And deep pain perception is the single most important prognostic feature. And of course, you need to obtain this after you have dealt with cardiovascular shock, because a very shocked animal is on adrenaline, and that will suppress any pain perception. And so you may not get the same response as you will with the animal as more stable. So, and this is the most important prognostic feature. Taking radiographs and CTs don't necessarily indicate the prognosis. And that's because the spinal canal can be, and the spinal column can be very, very elastic. So you can essentially have a complete dislocation, especially in a cat, that can go out and then pop back in again. And this CT here suggests a fracture through the vertebral body here at around about 76543 L3, and perhaps not much displacement there, may look okay, but when we do an MRI scan of this poor cat, we can actually see that there looks to be a complete severance of that spinal cord, and indeed this cat had no deep pain perception. It had all of this imaging at the owner's request, but the neuroexamination had told us the prognosis without that cost of that additional imaging. And so it is the neurological examination which is most important, not the emergency referral for imaging. And as a rule, thoracolumbar fractures, so in this sort of region, the caudal thoracic and cranial lumbar region, are much more likely to be devastating. And that's really because there is quite a small ratio of vertebral canal to spinal cord, i.e. there isn't a lot of room. And so if something happens, the spinal cord is much more likely to get damaged. So what is the significance of absent deep pain perception? Well, this is only lost in a severe spinal cord injury. And this is because this nociceptive information ascends by multiple and bilateral routes, many possible routes, many ways of getting there. Basically, everything you see in green is the way that nociceptive information, information about pain, can get to the brain. And so if it has not managed to find one of these routes to get to the brain, then the spinal cord is very damaged. And what we're looking for is a behavioral response from the dog or the cat at this end to show that the brain has got the message, not that the foot would withdraw, because this foot withdrawal is a reflex and will exist even if the spinal cord is severed. So we're looking for a behavioral response from the head end. So don't confuse with the flexor withdrawal reflex. That's just a local reflex, and it will even seem to be hyperactive if in some spinal cord injuries, especially in the T3 to L3 region, it'll sort of have like a double pullback, and it seems like the animal is trying to pull back or kick off this noxious insult. That's not enough. You need to see a behavioral response from the head end. Now, should these animals be referred? Well, I can tell you many neurologists will refuse the referral of an animal that has been injured in a road traffic accident, for example, that has no deep pain perception. And one of the reasons is that because the prognosis is so poor, and the owner needs to be told that before they make a several-hour journey, and have an expectation for that somebody is going to fix their animal for them. And it is not fair to the owner to make the referral vet be the one that gives the owner the prognosis, and not fair to the owner to give them unrealistic hope. Should you actually fix an animal if the spinal cord is functionally or actually severed? Well, putting the bones back together will not make a difference. And I would argue that just because you can doesn't mean you should. And there isn't really a strong argument that if these animals' bones aren't put back together in alignment, the animal is going to be in pain afterwards, even cranial to the lesion. That is very much a supposition. We see an awful lot of dogs imported from Eastern Europe in the UK, imported with long-standing fractures and devastating spinal cord injuries that are paraplegic and will never get function back again. And these dogs are not painful at the site of their lesion. So don't be a pseudo-hero. Just because you can doesn't mean you should. If you're thinking about it, ask yourself, is it fair for the recently traumatized animal to have surgery? And is the owner absolutely prepared mentally and financially and emotionally for the financial outlay when the surgery is very unlikely to make a difference, and more importantly, for the lifetime commitment of a paraplegic animal with a neurogenic bladder? And do they really know what that involves? Do you really know what that involves? Managing a neurogenic bladder is difficult. It's difficult to express the bladder fully. These animals get repeated urinary tract infections, and it's not just as simple as popping the animal in a cart and off it goes. So, our next, after assessing deep pain perception, our next step is to assess whether or not the spinal reflexes are intact. And the reason for this is used to localize where a problem is in the spinal cord. So the reflexes have a sensory arm and a motor arm. So we tap the patellar tendon and this stretches the stretch receptors, and that activates the lower motor neuron, and which in the case of the patellar tendon is the femoral nerve and the quadriceps muscle, and there is a kick of the leg. So we know that if this reflex is present, then the nerve roots, which is L4, L5 nerve roots for the femoral nerve, we know that those are intact. Likewise, if there is a withdrawal reflex, then we know that the sciatic nerve roots are intact. And so we use these reflexes to know that this segment of spinal cord is, or the nerve roots of this are intact. If the reflexes are hyperactive or intact, and we're just talking about paraplegia, where there is a inability to move the pelvic limbs, then this would then make the lesion in the T3 to L3 region, so damaging the upper motor neurons, but leaving the reflexes intact. If there is a failure of the reflexes, absent or reduced reflexes in the thoracic limbs, and the most important one for assessing that is the withdrawal reflex, and the panniculus cutaneous trunci reflex is also useful in this regard, then we can localize the lesion to C5, T2. And if the animal is tetraparetic or tetraplegic and all the reflexes are intact, then this makes it cranial to C5. Why is this important? Well, from a prognostic point of view, intumescence lesions, so this is this region here, the grey matter that is going to the nerve roots, the grey matter that's going to the nerve roots here. These lesions have a poorer prognosis than white matter lesions, where you have the axons travelling down. So a lesion between T3 and L3 damages those white matter tracks. Remember learning all of these? Remember wondering why you had to learn all of these? Well, actually, I don't need that people know all the different names of all of these tracks. But knowing that the white matter tracts are most predominant in the spinal cord in this region, that's the useful knowledge to have. So when we damage these white matter lesions, this axon, that potentially has, as long as there's not too big a gap, that potentially has the prospect of repairing, or that there be some compensation. But if I damage the grey matter and I damage that cell body, then that is not going to regenerate, and so that has a much poorer prognosis. So as a general rule, if the animal has lost its reflexes, then there is a poorer prognosis for improvement. Now, there is one thing that you need to take into account when you are assessing spinal cord reflexes, and we can see this in this little chap here. This dog does have a disc extrusion. And we can see when we're looking at these spinal reflexes in this dog, it doesn't have deep pain perception, so we're not going to get behavioural response from that. We can see the dog has quite low tone, but the reflexes are reduced, even though this dog has a thoracolumbar spinal cord lesion. So low tone and reduced reflexes. You can see here this low tone. And our perineal reflex, you just see the anus contracting there, the perineal reflex is intact, so that doesn't appear to be affected. Now we're just doing a cutaneous trunci or panniculus. And we can see the cutoff is there. So that's where the spinal cord lesion is. But why does this animal not have any reflexes? That doesn't fit. Because its localization is both here and here. Well, the reason is that it has spinal shock, and this is very typical immediately after a spinal cord injury. So it is where you have depressed spinal reflexes and reduced muscle tone causal to the cord injury. So basically your neurological examination suggests a T3 to L3 and an L4 to S2 localization. Most typically, you have this loss of flexure withdrawal reflex, and the other spinal reflexes, such as the peroneal reflexes, is intact. And it's not clear what is happening here, but it seems to be a physiological dysfunction of the lower motor neuron rather than a true structural lesion. However, there is a recovery in hours to days, rarely weeks. So it's worth being patient in that regard. And so, although I have said that having a lesion in the L4 to S2 region is a poorer prognosis, you need to be sure that it isn't spinal shock that you're dealing with. So your next step in general practice will probably be to obtain diagnostic imaging to obtain more information. And we can see here is rather devastating fracture of C2 through the vertebral body of C2. And of course, this is made so much worse because of the considerable dislocation here. You do need to take the entire spine because there may be more than one site of trauma. And ideally, these radiographs should be lateral and dorsal by an absolute minimum. You need to have at least 2 views. But you also should have oblique, because oblique are the only way that you can look at facet injuries. And as I've said in other videos in this series, it's actually quite challenging to get good spinal radiographs and challenging to get those oblique views. I do have a video on how to get a good spinal radiograph, but actually it takes some good practice. It's not something that you necessarily can do the first time that you try. And if you are doing it for the first time, then make sure that you look at a resource like my video. Some people have CT, and that is a definite advantage. It's quick, much quicker than taking a spinal radiograph. You can position the animal in sternal recumbency and limit their movement because, of course, really, if you suspect that their animal has a spinal injury, then you should be transporting it with as minimal movement as possible. It's often quoted to use a board. I think that sounds better than it actually is practically, although I would suggest that you try to do it. The problem is trying to keep the animal without moving on the board. It's not like a human where you can strap them in easily. What I tend to do is have 3 people on the animal, 1 person holding the head, 1 person holding the thoracic limbs and spine, and 1 person holding the pelvic limbs, and you all talk to each other and say when you're going to move the animal. So turning to lateral recumbency now, 1, 2, 3, go, so that you don't move the spine and twist it as much as possible. It's much easier to identify the facet injuries if you use CT, much easier to identify other injuries. For example, if you have a bladder rupture. Obviously, the disadvantage are considerable of cost and a lack of availability. I would prefer CT over MRI for the reasons that I've just said. MRI, however, does provide more information about the spinal cord, so we can potentially see compression by disc or hematoma. Although I would argue that in the vast majority of cases, the disc is a normal disc, so it's not like a controdystrophic dog, like a French bulldog or a dachshund that has abnormal nucleus pulposa that's likely to sit as a great big blob. In this instance, it's the torn annulus that usually comes back into alignment when you pull the vertebrae back into alignment, and the liquid nucleus pulposa, which is usually dissipated. So I would favor CT over MRI. However, as I've shown you in one image, it doesn't necessarily tell you how devastating that spinal cord injury is. However, your neurological examination always gives you more information for that. The other important thing about MRI is it can't be used for surgical planning. So what you need to do, and this is probably the more difficult thing, is to assess whether or not this injury is likely to be unstable. And for this, you need to assess the vertebral body, which we often refer to in this instance as the buttress, the facets, and the disc. And basically, you can usually assume that if there is a failure of the buttress, the vertebral body, then these is usually unstable, unless there is just a tiny little slab fracture off and there is a great deal of space, for example, at the lumbosacral junction. The intervertebral disc stabilizes against rotation and lateral bending. However, if this is the only thing that is gone, then external splinting may be enough. Failure of one facet only results in minimal instability, and anybody who does a hemilaminectomy will know that, because when we do a hemilaminectomy, we actually, if it's a full and proper hemilaminectomy, will destroy that facet, and it doesn't result in instability. However, if you have failure of two or more components, then it's usually unstable. So if you have damage to the facet and to the disc, then that is more likely to be unstable. To assess stability, you may need to very, very carefully do dynamic imaging. So this is an example at atlantoaxial subluxation. So there is a failure of the ligament between the dens and the basilar bone, the basio-occipital bone. And there's also a failure of the ligament between C2 and C1. So it looks relatively okay here, though this space is a little bit wider than you would expect. And when you flex, you can see that the dens is coming away from the atlas there, and that there is opening too much of this space. Again, it does take practice to take these images well, and I do provide some information on that in my spinal radiograph YouTube video. So, can you manage these non-surgically? Well, you may have to try if the owner doesn't have financial means, which is, let's face it, the vast majority of owners, because surgical management is expensive. So it's very important to give a good prognosis here, since it may be some time before you see improvement. So non-surgical management is suitable for cervical injuries unless the animal is deteriorating or the lesion is unstable. If it's unstable, then the animal is often deteriorating. And this, the reason why non-surgical management is often successful is that there is a large ratio of the vertebral canal to the nerve roots and the spinal cord. So there's a bit of room for the spinal cord to get out of the way. Same goes for the caudal lumbar region, so the L6, L7, the sacral region, the tail. Again, unless they're deteriorating or you've demonstrated instability, then these can probably be managed non-surgically. The thoracic and the cranial lumbar region, these are much more likely to have a devastating injury, so surgery may not be applicable because the animal is not going to regain walking ability, but you may have some success with surgical management with minor injuries where they have not lost deep pain perception. So you should splint the area of instability if it's at all possible. However, this can be quite challenging because you need to have the splint going above the area of the fracture. So if the fracture is at C2, as in this dog, then the splint cannot just end at the top of the neck, because then you're actually ending the splint actually on the fracture. So you're making it more likely that it will move. So really this splint needs to go to the medial canthus of the eye and prevent all movement of the neck. And to be honest, dogs and cats do not tolerate this degree of casting very well. They're really very poorly tolerant of it. This dog had a fracture lower down. It was able to get a splint that went either side. So really it needs to be as light as possible, but also as inflexible as possible. Just showing you an example of Dexter here is a 5-year-old lurcher who we call Mr. Boop because his nose is just boopable. And Dexter was out for his usual exercise, but he disappeared when he was running. Obviously, this was extremely concerning, and especially as he couldn't be found. And after 2 hours of searching, he was found non-ambulatory, tetraplegic next to a bush, and it's thought that he may have nearly had a collision or had a collision with that bush, but more importantly, twisted suddenly to avoid the obstacle, because that sort of sudden twist in this breed of dog can be enough to, associated with an impact, can be enough to cause such an injury. And very importantly, he had neck pain. And so we might have considered some other injuries like fibrocartilaginous embolism in this dog, but that would not result in this degree of pain. And so he had some radiographs, and as you can see here, he has a fracture and dislocation of between C5 and C6. It's most obvious to have the dislocation, but you don't get that kind of dislocation without having compromise to the disc, and importantly the facets as well. He is owned by a vet, and so we did do a MRI scan, and you can see here that the spinal cord is certainly intact, but you can see the area of high signal within it, and you can see this is the grey matter. And of course, as I told you before, a grey matter injury carries a poorer prognosis, and we can see the compromise to the disc. But importantly, we can't see any compression from that disc, and even though that liquid disc material is undoubtedly in the spinal canal, but it has been dissipated. So how was he managed? So he was managed with a plating, which was actually quite challenging to get that plate contoured to these vertebrae. Most important is to apply traction to the neck, first of all, to get these vertebrae into an alignment, and then the plate needs to be placed in enough vertebrae to provide stability. And you can see here there's a plate either side, and the screws going up into the vertebral body here. Now, it's very important after you've had such an injury, whether you're being managed surgically or non-surgically, that physiotherapy is part of the program. And this is because if you aren't having such things, then that inactivity and the recumbency will result in muscle contraction, especially if it's a lower motor neuron lesion. So we need to have short walks with support. I will often try to work with a physiotherapist to give a specialized program to improve that joint position sense and core strength. Moving up to these kind of balance apparatus is very much a last step. Very early on, you're just trying to get them to bear weight through those limbs, and also perhaps bear weight on 3 legs. So this was our boy after a few weeks after injury, and we can see here that he's able to walk weakly. He's having to have that weaker foot protected because he's scuffing it. And here he is some months after. He's injured in around May time, so this is about 6 months afterwards. And you see he's doing very well indeed. Mostly thanks to the physiotherapy employed by his mum, who I'd like to thank for allowing me to use in this video. And of course to Dexter as well. And thank you for listening to me. Bye-bye.